One 65 years old male came with the nocturia and 50 gram size of the prostate, and this patient asked for the surgical treatment. My dear friends, the patient is having significant symptoms of nocturia, and even then this patient does not require any surgical treatment because size of the prostate and nocturia, these two things does not require surgical treatment. Now the second question comes, where we require the surgical treatment or where we cannot give the medical treatment. This is number one is most important, and number one is chronic urinary retention. This is important because in this patient is not having much symptom. Patient is largely asymptomatic, but the severity of the disease is shown on ultrasound and blood investigation. On ultrasound there will be significant post-void residual urine. Bilateral hydronephrosis hydroureter because of the back pressure changes caused by the residual urine and leading to increased serum creatinine and blood urea. This findings can lead to chronic renal failure. So in this patients it is important to tell that if we will continue the medical treatment, then the disease can progress into the renal failure. The second condition comes where the medical treatment is not required, that is bladder stone. In that also, this bladder stone will not come out from the medical treatment. In other conditions where surgical treatment can be advised, number one is where patient is not ready to take the long-term treatment or not getting the satisfactory relief by the medicine. In that condition also we can advise surgical treatment. What surgical treatment is offered nowadays? That is transurethral resection of the prostate. Transurethral resection means the instrument is going through the urethra, through the external urethral meatus. Resection means cutting the prostate into small pieces. The cutting of the prostate is done by some energy source. This energy source is monopolar cautery, bipolar cautery and laser. In laser we use the holmium YAG. Now we have to understand that monopolar cautery and bipolar cautery are the most commonly used process. In this, monopolar cautery is the most common and the cheapest one. In monopolar cautery, the name itself you can understand there is one pole. From this one pole the current is going inside and the current is coming back through the body, pad capped under the body, and through this it will come back to the machine. But in the bipolar cautery, from the same pathway the current is going and coming back. It is not running through the body. So you can understand that monopolar cautery is spreading from the point where it is applied like this. But bipolar cautery is very precise. It is not spreading from away from the point of application. In monopolar cautery, it is important to know that normal saline and glycine, among these two, the glycine is used in monopolar cautery. Okay, because monopolar cautery will not function in normal saline. In bipolar cautery, we use the normal saline, because in bipolar cautery we can use glycine also, normal saline also, but normal saline is a better solution as compared to glycine. That's why in bipolar cautery we use normal saline. In monopolar cautery, glycine is used, not the normal saline, because the monopolar current will not work in monopolar cautery, in normal saline. Glycine having the another problem, if it absorbs, then it will increase the blood volume. but the sodium will remain the same, and that will lead to dilutional hyponatremia. And how we diagnose the dilutional hyponatremia? If in the post-operative period after TURP, patient is disoriented, like talking different things which is not normal, patient is drowsy, or patient is restless. In these conditions, we have to be very, very careful about dilutional hyponatremia. Sometimes we feel that the patient is restless, we can give the sedative to the patient. That will be a mistake. By giving sedative, we can worsen the condition of the patient. And if we do the serum sodium in this condition, sodium will come below 135. Normal is 135, it will come below 135. And we have to give the concentrated sodium chloride. This sodium correction is required to be done slowly. If it is done fast, it can lead to pontine myelinosis. Pontine myelinosis. In bipolar cautery, we use the normal saline. We can use glycine also, but normal saline is a better solution than glycine, because the normal saline is not going to cause the dilutional hyponatremia. Laser is better. Holmium laser is better, but costly. It is better because it causes the less bleeding. Next thing comes the complication of TURP. First and most important complication is bleeding. Prostate bleeds a lot. In postoperative period, there is always a problem of bleeding and clot retention. So for the precaution after operation, we put the Triway Foley catheter. That is 22 French. Normally we use the 14 French or 16 French. To dilute the bleeding, we use the irrigation in the postoperative period, that is normal saline. We can use glycine also, but normal saline is a better solution than glycine. That's why the normal saline is used in place of glycine. And another thing is we use the traction. Traction, how we put the traction? First we inflate the balloon to 50 ml. Normally it is inflated to 10 ml. And then we put a pressure, put a traction like this. You can say this. This catheter is stretched and tape is put a traction, so that it will compress the prostatic urethra or prostatic area from where the bleeding is coming. Now you can see that this is a normal catheter bi-way. This is to inflate the balloon. This is for outflow of the urine. In Triway, this is to inflate the balloon. This is to outflow of the urine. And this channel, extra channel, is for irrigation. And the balloon is inflated 50 ml. Number 2 complication is retrograde ejaculation. This retrograde ejaculation is because of damage to the internal sphincter. When we do surgery, we remove this part of the prostate, then this area is also damaged. This is internal sphincter. When this internal sphincter is damaged, then the internal sphincter or bladder neck will be open always. So whenever the semen is coming in this part of the urethra, prostatic urethra, it will go into the bladder in place of coming out. That is retrograde ejaculation. That will be present in all the patients who are undergoing TURP. Another complication comes because of the injury to the external sphincter. This is external sphincter. You can understand this external sphincter. If this external sphincter is damaged partially or completely, it will lead to stress incontinence. Whenever there will be stress like coughing, sneezing or lifting heavy weight, the urine will come out without knowledge. That urinary incontinence will be there. To avoid this complication, what is the criteria? To avoid this complication, it is important that dissection is to be kept proximal to the verumontanum, not beyond this. If it will be done beyond, then it will cause the damage to external urethral sphincter and leading to stress incontinence. Thank you.